This is QD Video, brought to you by RoomNow.live, where the goal is to inspire, inform, educate, and interact. More on that later. Our case from the clinic is the normal sed rate PMR patient. So I have this gentleman, he's 57, he comes to see me. He's been around the block with a few orthopedists. He's had neck injections, he's had shoulder injections. He feels horrible. Occasionally someone's given him a Medrol dose pack and he feels wonderful. And when I see him, he's got, pain up in here from his neck down to his shoulders. He's sore, he can hardly move, he can hardly raise his arms. His hips and thighs and low back are killing him. He has 1 to 2 hours of morning stiffness. He does not have any fever. He does not have any jaw claudication, anemia, LFTs, or weight loss. It's this stiffness and soreness, morning stiffness and soreness that is overtaken him and changed him dramatically since about 3 months ago. So, of course, I see him and say, you're a little young for PMR. Most of my PMRs are, about the average age of PMR, which is about 67 to 70 years of age. I don't diagnose many at 90. I don't diagnose many at 50. But it's still possible. The criteria says over the age of 50. So when you look at his labs, no anemia, no white count, sed rate is 1. But his CRP is marginally elevated at 9 milligrams per liter, and his platelet count is an unexplainable 490,000. Of course, he goes on 10 milligrams of prednisone, is now a champion, and there's no other evaluations that have been done on him have been negative, and this has been curative. So it's really to go over the case that's not the usual, meaning you like them to have a really sky-high sed rate and CRP, but that's not always the case. It turns out actually somewhere around 7 to 22% of patients with PMR will have a normal sed rate. If you look at other acute phase reactants, they'll occasionally be elevated, but they don't need to be. These kind of patients tend to be younger, tend not to have the other inflammatory features I just mentioned, that being anemia, fever, high white count, LFTs, weight loss. Those are not usually common. They tend to have a delay in diagnosis. They tend to be a little less female than do the very high sed rate PMR patients. And they tend to respond maybe a little better and get away with a little bit less steroids in the long run. So it happens. It happened to me. It could happen to you. Look out for such cases. Let me give you a reminder about the faculty we have for Room Now Live. It's incredible. It's on the website. It starts on Friday, the 22nd of March, with Mike Holler's John O'Shea. Mike Holler's on preclinical RA. John O'Shea talking about JAK inhibitors. He invented them, or he discovered them. Mike Weinblatt giving you a history of methotrexate, unlike anything you've ever heard. Eric Madison on the history of steroids. Ted Pincus, Fred Wolf, a safety session with Lisa Samaritano. In a previous recording, I said Lisa Sammartino. Don't know where I got that from. Know Lisa well. Maybe it has to do with my growing up idolizing Bruno Sammartino, another story. Len Calabrese talking about checkpoint inhibitors. I'll be talking about infections and how to manage them and prevent them. The next day, we're going to have a talk on the price of drugs from Maddie Feldman, Ron Van Vollenhoffen, Georg Schett, and Philip Conaghan, the masters of the EU, doing TED-like talks. Session on psoriatic arthritis that features Artie Kavanaugh, Philip Conaghan, and Craig Leonardi. They'll blow your socks off. A session on lupus with Ken Kalunian, Richie Fury, and Dorian Erkin talking about the antiphospholipid and catastrophic antiphospholipid syndrome. We have an orthopedic session, a vasculitis session, and a spondylitis session we're going to end with. Carol Langford, Philip Seo, Paul Monarch from the Brigham, and then spondylitis, John Ravel, Eric Ruderman, and Elaine Husney. It's a killer lineup. RoomNow.live, check it out.